I like this quote from Meg Spriggs, who's, I believe, the lead author on that study, is that we need to reframe the question. It's not necessarily how do we treat anorexia. Instead, the problem we need to address is how do we help people engage in the process of recovery? And so just some food for thought as we move forward. This is UCSD. The paper was published just last year, Peck and colleagues, Walter Kay's lab, and in collaboration with Compass Pathways. Compass was a nonprofit, now for profit. I'm doing their phase 3 studies in Utah of psilocybin for treatment-resistant depression, but not the anorexia study here in Utah. They gave they had 10 patients in the study, got one dose of synthetic psilocybin. I put a rough equivalent in if you're used to looking at these things in like dried grams. And 30% had significant reductions in symptoms after 1 month. Interestingly, a month later, this rose a little bit. 90% of the participants found the experience to be meaningful and therapeutic. It's hard to pinpoint exactly what comes of a study, but that's a good sign there. And the safety was good. I'll let you look at this on your own if you would like. So we can move ahead to, I think, one other medicine being explored. This one called TNX 1900, which is an intranasal oxytocin. Oxytocin combination. An oxytocin formulation specifically made for the bioavailability. This has been a challenge with oxytocin studies because the idea is great, but in the real world, it's been hard to turn this into a useful treatment. But this is actually a drug device combo that uses a special way of delivering it to make sure it gets there. And the preliminary data is showing that's the rationale for doing the full phase 2 is reduced impulsivity and food intake. This one is ongoing. I was the coordinating investigator for this for maybe the first year or so to help get it the protocol through the US FDA and Health Canada and help train the sites to get them going. And it's a slow moving study. It hasn't been a big priority because as you have likely heard if you followed the psychedelic news, is that MAPS, now called Lykos, did not get MDMA approved for PTSD. We'll talk about that a bit more. And they were asked to do another study. So that's been kind of an all hands on deck, regrouping to try and get that important milestone redone. So, and this is the dose and the study design with an imaging add-on in case you want to see how it's being done. But what's really interesting about this study, that's anorexia and binge eating, a small pilot study. The interesting thing is the caregiver involvement, which we're a big fan of in the eating disorder community, and at Center for Change included, and especially, and I like to include in studies wherever possible. We'll talk about that with ketamine, but so before we dive into psychedelics as a potential treatment and what would that look like, let's look at the neurotransmitters at play here. We've got this thing called serotonin, that is all over our brains and our guts and involved in our mood, anxiety, our sense of of social place in the world. And when kind of out of whack can really impact our temperament, our obsessionality, even our memory learning, our behavior, our ability to inhibit behaviors, things like that. So in anorexia, the spikes of dopamine that used to come or might come compared to another person get kind of numbed out, diminished, and food becomes more anxiety provoking than pleasurable after a while. And you don't get the same reinforcement of the role that dopamine plays, because dopamine evolved the way it did because it helps the species survive, like seeking food for survival, reproducing for survival. And so in binge eating disorder, the spikes kind of come in anticipation early. There's this hyper responsiveness. We'll talk about this pendulum of sorts, the spectrum of over control and under control in a bit. And then acetylcholine is of interest. We won't focus on it as much today. And let's jump into psychedelics. These labels here, blue means it's made in a lab. Green means it can be, it was naturally derived, can be naturally produced, although in studies like with psilocybin, all of the studies we're doing in our research clinic, because there's sponsored studies along the FDA drug development path, they're all using synthetic psilocybin. We would love to be able to use naturally derived ones, and there are labs working on that. And I think there's a path to that, but the path of least resistance, the mandatory path so far, at least this FDA clinical research path, the area I work in mostly, it requires synthetic. This is different than like the psilocybin therapy program in Oregon. That's a state regulated program where they do use natural derived psilocybin. This is how they're categorized. And you can see how ketamine is kind of in a class of its own, and MDMA kind of a class of its own, sometimes lumped in with the phenethylamines. And so this is the Renaissance, kind of chapter 1 and 2, back in the 50s and 60s, where there was the first surge in research. LSDs first synthesized in the late 30s. Albert Hofmann was the same person who synthesized LSD was the one who figured out the structure of and how to make psilocybin in a lab. That was in the later 50s. And then this was being sent around kind of freely then for research purposes. And then fast forward until the 2000s, some research kicked off in the UK, at Johns Hopkins, other areas. And now we have a number of these drugs, psilocybin, LSD now have breakthrough therapy status, MDMA, from the FDA for their evaluation. But unfortunately, last month, the FDA rejected MDMA assisted therapy for PTSD. There was a lot of drama around that. And I won't get into it because it's complicated and frustrating and all that. So we'll save that for another day. But looking back at Albert Hofmann's story, he made LSD in 1938, but then he accidentally dipped his finger in it a number of years later and had this weird experience. So then he said, okay, I'm going to take a specific amount and have my lab assistant kind of babysit. And so he did. And this is what's known as Bicycle Day. I think it's April 19th. It gets commemorated. And what I point out here is that he had both difficult things come up and mystical things. And that is more common than not when using these medicines, and may in fact be part of the mechanism of action for how and why they seem to help in some individuals. Some might just have a mystical experience. Some might have just a difficult experience. Some may have both. And we do measure these things in these studies. It's really fascinating to try and pinpoint, like, did someone have a complete mystical experience across these domains, for example? But when LSD was freely sent around by Sandoz Laboratories, including to psychiatrists all over the US and Canada, they said, you could try this for a couple different things, as a therapy aid or as an experimental model of psychosis. And because it does bring about these hallucinations, these perceptual changes, delusions, even, if you will, although temporarily, and although the person sitting, and hopefully for most of the time, the individual experiencing it will remember that this is temporary and they can relax into it and use the experience. Whereas in psychosis, it's a different kind of, it's a very different situation, whereas it is not a transient thing. And this is how, just to complete our big picture view, this is how psychedelic assisted therapy works in general, and this is how our study protocols are. So people come in for one or more preparation sessions. We get to know them. They get to know the two therapists who will be sitting with them, one or two, and then we start to educate on what to expect and get ready for the session, how to navigate it, what is one's intention. We start to set some targets of what the individual is hoping to get out of this work. And then the dosing session for the LSD study, they were 12 hours in the last study. It'll be 10 hours in this next phase. The psilocybin ones are more like 6 hours or so. And we're doing a postpartum depression study of a shorter acting psychedelic that's even less. And the 5-MeO-DMT is probably the shortest of the ones we're studying, which is really just an hour or less dosing session, and which matters as we think about how to integrate these things into everyday healthcare, into clinic. And then after, the day after, in these studies and in practice, ideally, we do an integration session. This might be 90 minutes or so, looking at what came up and how do we weave it into the intention, the goals, the treatment plan, and how do we, especially during this window of opportunity where things seem to be more malleable, how do we make lasting changes stick? And so there has been some research look at psychedelics and their impact on well-being and depression and things in population survey studies. And some of those have looked at eating disorder symptoms from those seeking psychedelic experiences. And I'll just summarize it here that there were some positive signals, positive enough signals to suggest, yes, this is worth exploring further. And why? Well, this we'll break this down stepwise here, because the mechanisms of psychedelics, including ketamine, are both biological and psychological. It may go without saying, but I think it's important just to emphasize here is that like when we give someone ketamine in clinic, there is an antidepressant effect chemically. For the majority of people, it's an individual thing how long that lasts and how dramatic of an effect. And even if someone will get it, but the majority of people seem to get it. And then we've seen through the years of working with it that when you pair it with therapy, and it's still being worked out what kinds of therapy, how much, how long, when you pair it with therapy, it seems to be an even better combo. Like I was saying earlier, that therapy, that meds plus therapy is better than meds alone. It's kind of how we view ketamine and how we view psilocybin. There could be changes in the brain that come out and behavior, and that or a window of opportunity that comes up. And we want to use that as much as we can. And the mechanism, I guess you could try and break down two ways. That giving a classic psychedelic like psilocybin for an eating disorder may have some benefit, we'll talk about, into serotonergic signaling, more cognitive flexibility, more, and this brain state that makes therapy easier to receive. You have this introspection and you have this ability to shape patterns. So when you combine that, seeing the patterns more clearly from a new perspective and having them be shifted, replaced with new patterns more readily than they were when you were in the throes of it, and that really stuck place before taking the medicine, the therapy aid, if you will. And so this is what it looked like in an Imperial College study, a small early depression study that I show here, because you can see how after 1 week, when they measured the depression, people get psilocybin. After 1 week, the depression score dropped a bunch. It dropped even more by the next week. Then it started to creep back up. And 6 months later, there are still some benefits. But a question that I've gotten really interested in is how do we first get the most benefit out of this med plus therapy combo, and how do we make that lasting positive change stay for as long as possible. And interestingly, if you look at, like, this is out of Gould Dolan's lab, who studies the critical period, or this window of opportunity that opens up where you can shape things. We call it a critical reward and learning period, because things just get kind of shaken up, so you can insert new patterns, but that window doesn't stay open forever. And these are estimates. They're mostly based on animal models, but it's interesting to me how it kind of correlates with the half-life of the med, the duration of the dosing experience a little bit. I don't know if that means anything, but we do clinically, at least based on this hypothesis that we have this window of opportunity, we work with that as much as we can. And let's take a little tangent for a moment. This is something a question I've kind of sat with and been a bit puzzled over since the very beginning of my career. Like, why do some meds, SSRIs included, work for very different conditions that seem even on other ends of a spectrum? Like, if you were to plot mental health conditions, or even states of consciousness across the spectrum of chaos or disorder to control, rigidity, you'd have something like OCD on one extreme and psychosis on the other extreme. And you could see how, like, a binge eating pattern where you're unable to stop the behavior might fall more on the chaos side, and anorexia, where you're unable to make yourself eat, on more of the over control. So I'll just leave that question there. And I find it interesting to look for comparison at psilocybin for OCD. When we're thinking about, might psychedelics help for eating disorders? And how about anorexia in particular? Anorexia shares some things in common with OCD. There is some shared heritability, even, like they co-occur at a higher rate than would be seen just by chance. So the etiology of OCD, like all these things, is multifactorial. It's never nature or nurture alone. It's always some combination of both. And there are psychological aspects, and then there are these genetic and biological and structural changes over time and at birth. So in the psychological realm, there have been a lot of papers trying to pinpoint what are the cognitive patterns that show up. One I'm showing here is from Jung. These are early maladaptive schemas when looking at OCD in particular, but we could extrapolate these to other conditions. And these schemes are different kind of maladaptive themes or ways of relating to self and others and the environment that show up in childhood as a response to unmet emotional needs, and often with a genetic predisposition for something on board. And these we carry into adulthood by way of memories, tightly held beliefs, bodily sensations, emotional schemas, and patterns. And so psilocybin is being explored in even more clinical trials than anorexia currently. Not that it's any further along. I think there's just been one main clinical trial published, but I think it helps to draw some parallels because it's being explored. A lot of researchers will say because of its ability to both introduce this introspection and change your mind, change your thinking patterns to help reframe these maladaptive schemes. So let's continue this tangent for a moment, and I'm gonna go really fast here so we can get to the meat of it on how does therapy work? Just a quick primer or big picture overview. If we put aside what kind of therapy we're doing, when someone comes in and does talk therapy with a psychotherapist, I think you could boil it down to we're trying to help the individual with deeply entrenched maladaptive patterns, patterns of behavior, thinking, feeling, um, that get the individual in some kind of trouble in the world, maladaptive, not conducive to where they want to need to be. And there's a reason why these are entrenched, because they're patterns, and we are what we repeat as humans, what we repeatedly do, we tends to occur over and over. And there's a saying in therapy that if it's hysterical, it's historical. Meaning, if someone's reaction to a trigger or something is out of proportion to the thing, there's a very good chance it may be what you could call a causal misattribution from childhood, or a way of showing our internal mechanisms of vulnerability, what we might need to work on. And psychedelics kind of work in a similar way. I'll get to that. Not that they just trigger you, but they do bring things to the surface, so they can be seen and worked on. And so change, there are a couple main ways that I'll just briefly summarize, like the classic Pavlovian conditioning, where if you have a loud noise and you startle because you were exposed to something very traumatic with a loud noise in combat, for example, if you start to reactivate that, but in a safe and supported place with some conscious, with some conscious awareness, let me get that back on slideshow. There we go. If you do it in a safe and supported place, then your brain starts to learn that the war is over and the startle starts to diminish. And this does take time, not necessarily permanent either, but kind of extinguishes slowly, comes back, can creep back in slowly. And then there's another mechanism when you get a state of activation on board, like when triggered, or when when you're working in the here and now with content as it's on board, you can work on it. And that's kind of a mechanism we'll take and use in this exploration of psychedelic therapy for eating disorders. And then one other one that I like, speaks to that caregiver thing we were talking about, among other things, is that when a client comes into therapy and they're expecting that as soon as they say something, that they're going to get rejected, judged. They're going to have more evidence to be down on themselves and hold this thing about themselves in this shameful way. But when that doesn't happen, when the therapist holds that for them and does not judge or reject them and continues to give them this unconditional positive regard, like Carl Rogers would say, or this this in this loving container, if you will, this creates that mismatch or prediction error and a way to reshape that or use that activated thing to reconsolidate it in a new way. And so let's look at how this relates to psychedelics. So there's this brain theory called the entropic brain, or based on the free energy principle. And basically it says that we're these prediction machines walking around the world, constantly taking in sensory input through all of our senses and comparing it with what we're holding in our mental models of the world, and we make predictions of what's going to happen and behave accordingly. And so, and then the higher levels send the predictions down, the lower levels bring the sensory input up. When prediction errors occur, this can get kind of reconfigured. And so when there's that mismatch, you can either update the information with the new sensory data, or you can ignore it. And the tighter these maladaptive beliefs are held onto, the harder they are to replace or update with this new sensory information. And sometimes, like in certain eating disorders, for example, we can be kind of tuning out entirely some of that sensory input coming in. And so when you give a psychedelic and there's this initial blast of serotonin from the 5-HT2A receptor stimulation, um, and an impact on brain network dynamics that really kind of shakes things up. It's thought to have um, a loosening effect, or you could see it as heating up the brain, not literally with temperature, but heating it up so it's more malleable, increasing plasticity, weakening the influence that those tightly held priors have that was overriding all the sensory input before. But I've had people coming out of like a ketamine session even saying, oh, I found my hunger or fullness cues. Like that's not everyone, and that's not the norm or predicted or something coming out of studies yet, but just as an example. And as the brain kind of cools, the hierarchy reforms, and as that window of opportunity closes, you can see how lasting changes may persist even after the substance is gone. And so let's look at it, SSRIs versus psychedelics. And I want to be careful not to knock on SSRIs because I prescribe them when needed, and they are a very important tool, whether we're talking about depression or bulimia. And they have a trade-off too. There is some more emotional blunting. Like you're kind of putting the emotional system in a cast for a while is one way to look at it. And with psychedelics, you have more of an emotional release or reconnection with that. And it can be difficult during that experience or reconnection. But they're kind of two different approaches, both in this very broad and far-reaching serotonin system. So let's look at psilocybin over the next maybe 10, 12 minutes, try and leave some time for questions at the end. And we can stay over if there are remaining questions a little bit. But this I like to point out because psilocybin actually has a case report for anorexia published in the literature. And the case report was dating back to the late 1950s. This is pretty soon after Albert Hofmann had reverse engineered psilocybin, if you will. Sent it around to research buddies, colleagues. Some ended up in Paris and they were studying it for a variety of things. And this is a case report of severe anorexia where the woman was given a dose of psilocybin initially, and she was on, I think, Thorazine already, and through that they didn't really know that there was a blunting effect. They didn't know much of how to use it. Set and setting wasn't really a thing. Like in this study, they had people going around different cognitive tests, etc. It was not the most pleasant environment for being on a medicine like this with what we know now. But even though they didn't see much change in her from the first dose, she went back to her room and had this mystical experience and told them about it and had some openness and initial change. They gave her another dose after the Thorazine was gone, and she did have some dramatic improvement for a short period of time at least. Switching gears to depression, this is one that we were involved in that was published last fall. 104 participants got one dose of psilocybin for depression. And in this one, we used niacin instead of placebo because if you know niacin, there could be some skin flushing, tingling, or some kind of reaction. Just have it be more of an active placebo. Like in ketamine studies, we'll often give a midazolam benzo med as the placebo group. And in a TMS study, that's a magnetic like helmet, we'll do a helmet that makes noise but doesn't do the same thing to try and match it as much as possible. So this is just a summary of, I like looking at it in this top right. I find that the easiest, but you can see the change in baseline depression score on psilocybin versus placebo was very significant. And this is for Gene full speed ahead. We're already in phase 3 studies of this right now. This is one of the studies you could send someone to be evaluated for if they have major depressive disorder and meet the criteria. But and this is this is a study that just came out a few days ago that I thought was really interesting. It looked at how many people are depressed in the US, how many people would potentially qualify for psilocybin-assisted therapy if approved. And this is by Chuck Raison, who was the lead researcher on that paper I just mentioned, and kind of runs this clinical trial. The psychiatrist in charge for USONA, who's bringing psilocybin through that phase 3 study for depression. And they looked at these criteria in this table on the right that are in these studies, like you can't participate in the study if you've had an episode of psychosis, a suicide attempt in the last year, although a lot of these can and should be debated, of course, in the real world clinically, but we get extra restrictive in studies, both for initial safety and for studying a very specific thing. So the paper explored which one of these makes sense to include, looked at that category of people who would potentially qualify. And just to point out that this, if approved, addresses such a big unmet need that we should really pay a lot of attention to how this rollout might look like. What would insurance coverage look like? How do we get people access, equitable access, and what are the real world considerations, et cetera? So I thought I'd show this as another psychedelic, not for eating disorders, but we did a study of this with MindMed. We were one of the sites of LSD. It's called MM120 as the study drug, LSD for generalized anxiety disorder. And it was a dose finding study. So it was not only looking at, is LSD better than placebo? One dose. Is it better than placebo for anxiety? And which dose is best? And so it turns out that the doses 100 micrograms and 200 micrograms did the best. And if you're looking at what it seems to be the best balance of safety and efficacy, because the rate of, say, difficult experiences during the dosing session goes up. And we're looking, some difficulty, manageable difficulty is good, but we don't want an overwhelming experience for people. There can be bad trips. I know it's a debated thing, but so this study landed on 100 milligrams. And what's interesting is the first study that shows a benefit one day after treatment. This hasn't been published yet, by the way, but we have presented it in posters and things at a number of meetings since the results were announced earlier this year. And we have submitted it for publications in review. Ooh, there's my alarm that we're running out of time. So this is exciting, and this is moving into phase 3. I'm just waiting for the DEA to say we can do it. There are a lot of hoops to jump through in this work. MDMA, I'm going to skip over, and I'll just summarize a little bit. We'll take a bird's eye view of what's going on in the ketamine world with eating disorders. In ketamine, we use in a number of different ways in clinic. So when I first studied it, it was as a psychiatric medicine, like IV ketamine for depression. And then Spravato came out, and we use that a lot in clinic too, as an intranasal version of ketamine. It's esketamine, twice a week for the first month, once a week for the next, and then individualized from there. And it doesn't have to be paired with therapy. That wasn't studied, but we always operate with this same belief that for most people, when feasible, therapy plus meds is better than meds alone. There is this interesting combination we do sometimes of low dose, like a lozenge of ketamine before a therapy session. And the more traditional way, and the way that's being shown in these psychedelic studies, is this ketamine-assisted psychotherapy model where we'll do some preparation, we'll have a dosing session, we'll integrate, maybe another dosing session, integrate, repeat in an individualized way. And then, so this is what has come out in the literature so far. There's one other page here. looking at ketamine or esketamine for eating disorders. Because I've reported some of these in past years, I'll focus mostly on what's new. And we did publish, and this bottom one is a group ketamine pilot program that we did at Center for Change. I have a slide or two. I did talk about that in the past webinars, so I won't spend too much time on it. But since then, we've also worked with some colleagues at King's College in London, Keeler and others, and published from our Utah clinic data how some individuals with eating disorders did on ketamine and on Spravato in terms of, this wasn't a formal study, so we have the data that we have, and we can look at their anxiety and depression scores. And so all of them felt better, but when we looked at it, the Spravato actually seemed to do even better. We can't conclude anything from this yet, but seemed to do a little better in the depression score numbers and weight. It was well tolerated. Weight remained pretty stable. There have been some other studies. This is the oldest one, back from the late 90s, a brave early study that explored a very long ketamine infusion, which, back then, not as much was known about it. And I thought this was a clever design and some really interesting results, even though you can see how it's harder to apply to the real world at that infusion rate. But it did fuel some further study because there were decreases in compulsive behaviors and thinking patterns. Quite a positive signal in those who got ketamine. This is our group ketamine pilot program that we published, where we did 4 people in a group, 1 dosing per week for 4 weeks, and it was really neat to see the individuals do this together as a group. They reported that it was, it gave them courage and insight from each other. And we got to discuss together after, and then they had their individual therapy and dietary sessions. And we saw depression scores go down, anxiety scores go down, and overall, really positive feedback suggesting that we explore this more. And we explored this in another model for anorexia. This hasn't been published yet, but where we gave IM ketamine and had caregivers coach with some support skills in parallel. And then we saw depression scores go down, some improvement in the eating disorder scores, some improvement in the sense of embodiment as well. And so I'm out of time if we want to leave time for questions, but just a couple of closing thoughts are that I'm especially excited about how this field of psychedelic therapy brings the conversation of spirituality back into the equation. I learned a lot from my former mentor, former boss, Mike Barrett, who was CEO of Center for Change when he hired me 7 years ago, and was running these spirituality groups, and really literally kind of wrote the book on spirituality and eating disorders. And I saw that play out as such an important role to bring in whatever spirituality means to that individual. So that's one thing that gives me a lot of hope and excitement. And I certainly am all in on continuing to pursue this, and think it needs to be in a collaborative way. I think, like Meg Spriggs said in that quote earlier for the anorexia study, how do we help the individual get on this recovery path in the best possible way? And that'll take a team approach. It'll take integrating it with the methods we use already, and doing it in the safest, smartest way we possibly can forward. But thank you for listening. Thank you for being here, and I'll just take some questions.
Thank you, Dr. Robison. As you can imagine, we have a ton of questions, and I'll do my very best to get to a few. I want to do a couple of quick housekeeping things. We recognize that at the top of the hour, many of you may have clients that you need to get to. So if you need to hop off, we certainly understand. We'll try and go over a few minutes and get to some of the questions. But before we do that, two things. When we end the webinar or when you leave the webinar, you will see a webinar evaluation pop up on the screen that you're looking at now. And if you would be so kind as to take just a few minutes to complete that evaluation, we would appreciate it. It's a continuing education requirement for us. It's completely anonymous, so feel free to be candid in your feedback. We tabulate those results and send those to the CE approval bodies. And then when we end the webinar, or if you leave, then in a separate tab, you will see the link to take the test. You must take the test online in order to receive continuing education credit. That's done through ClassMarker. So you'll see that link. Once you take the test and pass it, then this continuing education certificate will be available for download on ClassMarker. So look for that on your screen. And keep in mind, again, it's going to be in a separate screen when the webinar ends or when you leave. So if you have multiple tabs up, look for it at the back, because that's probably where it is. All right, Dr. Robison.
What do you need to pass on this quiz, by the way? I forget,
80%. And not that anyone of you will have to, but you can take it as many times as you need. So, and it will tell you what the answers are if you got one wrong. So then you can go back and do it again. So don't stress. You're welcome to take it again if you need.
And I'll give some hints as we go through the Q&A as I can fit them in here.
Okay, sounds good. All right, let me get to the bottom. So keep in mind, these came in order. So this will be from your early part of your presentation. Okay, let's see. Mike asks, in regards to ketamine trials, what do you make of the landmark study that showed when the comparison group was pre-treated with naloxone that they did not achieve psychiatric benefit? Any implications for risks of misuse, tolerance, or dependence?
Yeah, it's a good question and an astute one. And that was Alan Schatzberg's group at Stanford, I believe. And it wasn't, I don't know that I'd call it a landmark study. It was a small study and a controversial one in terms of its applicability. And I saw it debated heavily in the psychiatry meetings since then. But I think ketamine can be a godsend for some people and can be the worst possible thing for those at risk for like abuse, misuse, dependence, diversion, and all that. When we have Spravato, like esketamine, approved to give for depression, treatment-resistant depression, only in clinic. I've supervised tens of thousands of doses of that, and we have not had a single case of abuse, misuse, or diversion because it's so controlled. So I don't think it applies there. I think ketamine, mostly independent of this naltrexone kind of mechanism, is a drug of abuse, and there's some people who should avoid it, and some people, and there's a way, and there's a lot of care that should go into prescribing it. So I'll just leave it there for now and say that yes, all of these meds, all the meds we deal with have a potential dark side, and it's important for that to be a part of the conversation for sure.
Thank you. Okay, Elizabeth asks, are there studies yet on TMS and eating disorders as helpful treatment? And maybe Dr. Robison, maybe you can just give a real quick brief introduction about what TMS is in case there are folks who don't know, and as you answer that.
TMS is really interesting. It's this MRI strength magnet that you often shows up as a helmet that goes on top of the head, at least in the devices we use here in Utah from a company called Brainsway. And what it does is it delivers like thousands of electrical impulses to activate the neurons in a certain brain area. Like in depression, we'll wake up an area in the dorsolateral prefrontal cortex. In OCD, we'll have someone think of something distressing related to, they might think of like licking a doorknob or something like that. We'll activate an area and then we'll hit the button. It is approved for depression, OCD, smoking cessation, but not for eating disorders. It has been studied for eating disorders. A lot of those you can find on the Brains Way website. They're a TMS manufacturer who does a lot of this research. I really like that group, and I've worked with them a lot, and you can see summaries of their pilot studies for eating disorders there. And I wanted to include a section on that, but as you can see, I went overboard on the slides as is. So
That's okay.
Yeah.
Thank you. Okay, we had a number of attendees who were asking about where they can go for more information if they're interested in being a participant in the BED study.
Yes. So the BED study, you can go to cedarclinicalresearch.com, and let me see if I can actually put it in the chat. Yes, I can. I'm going to put this in the chat if it works, a flyer for it.
Good luck. We were having some tech issues earlier, and it wouldn't let Shelly put anything in the chat, but it would let me.
Okay,
So
this will just go to you, Tamara, but
okay.
you're welcome to put it in there if you'd like. It's a flyer for the study. And then that link, cedarclinicalresearch.com, has the phone number or a form. If binge eating isn't listed on the website yet, it's just because they're hurrying to add it. The flyer has it all, and or just reach out to me through any of those things I put on the first or last slide.
Thank you. Okay, Amber asks, is there evidence that supports or exhibits concern regarding age for this type of treatment? Parentheses, can it be safely / effectively used on adolescents?
At first, I was wondering if you were asking about geriatric use. Yeah, it's interesting. I got a question from a good friend and clinical colleague yesterday, like, where could I send an adolescent in Denver for ketamine-assisted psychotherapy? And that question is probably easier to answer in Denver than most places, but hard to answer anywhere because, yeah, it's just people understandably are much more hesitant in working with some of the controlled substances and people who aren't adults. So I use it when use ketamine. Can't use esketamine because not approved. Spravato is not approved for adolescents, so we can't. But I use ketamine carefully for adolescents. Sometimes when other things have failed, and there are just special considerations around the informed consent, around the developing brain, around all those things that like you'd take into account with any intervention. So it is harder to find, and the studies generally start with adults, but there have been ketamine studies looking at like adolescent bipolar and a fear of harm phenotype, for example, and showed like intranasal ketamine was really positive, a number of things like that, and a lot more work to do. I listed some of the age groups in the ketamine table in the slides if you want to take a look.
Thank you. We'll do one more question. This is from an anonymous attendee. I really liked this question because I feel similarly. The question is, I'm a master's level therapist treating eating disorders in outpatient. What do you suggest I do with the information you've shared? I'm very interested in the application of these innovative approaches, but don't know what to do with that energy.
Yeah, good question.
Yeah, I loved it.
Thank you for that. And that may help inform a talk next year if I get asked to do this again, even though I always have too many slides and late on my deadlines. Tamara.
It's all right. We forgive you. It's all good.
What to do with this is the only one of these medicines that we've been talking about that we can give in clinics in Utah right now is ketamine and esketamine for adults. So if you have a client who is, say, a client who has an eating disorder and comorbid depression, this is like a clear example, who is stuck, or the depression seems to be really interfering with their ability to make progress, you could consider sending them somewhere to get evaluated for a course of ketamine. And the interesting thing about that is someone could go get a course of ketamine for depression, whether it's in the traditional IV way or in an IV plus guided therapy, an injection with therapy, all variations of this theme, it still does the same kind of thing we're talking about. It still gives you a chance to work with the client in a new way during that course of treatment. So I would say get informed more first by the free resources out there. Like at Numinous, we have a free webinar course or two. And of course, there are paid ones, but I'd say soak up some of this knowledge of what that would look like. How would you work with someone in ketamine assisted psychotherapy? Because you can use that as your clients go through a course of treatment. And then these other things are coming down the pipeline and will eventually be approved, some of them. And so we're also getting ready for what's next and keeping hope for what's on the horizon. But yeah, thanks for that question.
Yeah, thank you. My thanks to Dr. Robison and to all of you for participating with us today. It was wonderful. I thoroughly enjoyed it and learned a lot, as I always do when Dr. Robison presents. So my thanks to you, Dr. Robison, and to all of our attendees for your time today. We hope you can join us next time. Our next webinar is in November. You'll see emails if you're on our email distribution list. If not, reach out. I'm happy to add you. And you can also go to our website to the professionals tab and then click on the webinars tab and you'll see the webinars that are upcoming. In the meantime, everybody, thanks again and be well. Bye.
Thank you.